Thanks, I think.
Sorry, I forgot to start the recording.
Do others see the QR code?
I see it. The bottom is cut off, so it's not scanning. I don't
Oh.
know, just scrolling down my over.
Taskbar. Let's see. How do you get rid of the I think the taskbar is. Oh. Yeah, I see what you're saying. Maybe if I just make it a little bit smaller. Oh, there we go. Is that better?
Yes, I think that worked. And there's also the link to menti.com in the chat now that you can use with the code. So
Yes, that works as well. There's just a couple questions. So I'll put that in the chat, actually. Find the chat. So Julie, let me know when you want to start.
Yeah, we'll just give it like 30 more seconds. Got a few more people who just joined. All right, seeing a bunch of thumbs up, so why don't we go ahead and get started?
Do you want to share your agenda first, or should I just start with this?
Sure, I can I can share my agenda first here. Go back to my screen. Okay. So hopefully everybody can see my screen again here. So again, welcome everybody. So today's agenda pretty straightforward, but just again, thank you for joining today's webinar. I am so excited to see everybody here. This is I think a record since we've started doing these clinical services advancement webinars. So really excited to see you all here with us today to hear about our billing practices and revenue generating opportunities. So definitely a hot topic and one that will be visited again in a slightly different format at annual in a couple months here. So come check it out again there and continue. We can continue to share our best practices and hopefully all learn from sharing and collaborating together and learning what we're all doing. So really excited again to have Dr. Sarah Billups and Lisa Kroon share a little bit of experiences first here about their practices. And then after they share what they are doing at their facilities, we are all going to break out. We have facilitators amongst our clinical services subcommittee that will be facilitating as along with Dr. Billups and Kroon. We'll also be serving as a facilitator. So we have everybody into different breakout groups And we will be kind of leading some different sessions. We will ask you to, just because the groups are going to be a little bit larger in size because of the number of people here today, we'll ask you to just share your name and practice site and whether or not you're billing in the chat when you get into your breakout room. And then your facilitators will lead just some kind of popcorn session questions when you're in your group. And then we'll have some time to kind of just share some thoughts and questions and collaborate. Come back into this main session after about 20 minutes and kind of wrap up, recap, and go from there. So hopefully we'll wrap up right around 1:15, get you back to your day on this lovely Wednesday hump day of the week. And so that's the plan for today. So with that, I will turn it over to Dr. Billups and get us going.
Thanks, Julie. So my name is Sarah Billups. I'm an associate professor at CU Skate School of Pharmacy in Denver and director. Can you hear okay?
Yeah, I was just, you're sharing your screen now, right?
Yes.
Okay, perfect.
Okay. And director of population health pharmacy here. And here at University of Colorado, we've been doing some different interventions to try to work on billing. And first, I want to see what you guys are all doing. So first polling question there is, where is your ambulatory practice with respect to pharmacist billing? So the options are, of course, you haven't started doing any billing, or you're doing some, but not substantial, which is sort of open to interpretation, but billing substantially, but less than half of your pharmacist FTE, that, and or else you're generating revenue that supports at least half your pharmacist FTE. So it looks like there's at least maybe one group that is doing that. Congratulations to you. I will say that we here in Colorado are probably more along those, the third category there. Then the next question on here is, which insurers are you billing? And that you should be able to check all that are applicable in there. So of course, one option is none if you're not doing this. Other is Medicaid, Medicare, or commercial. Medicaid, of course, is a little easier if you're in a state that recognizes pharmacists as providers. And it looks like actually the most popular one is Medicare. Right. Thank you for your participation. So our official title is RX Review, Expanding the Value in Ambulatory Care. And I'm going to start just telling you a little bit about the setting where I practice. We have 15 primary care practices at the University of Colorado, and 8 of those are hospital-based or hospital-owned, and 7 are what we call community practices. Each of these does have an embedded pharmacist FTE, and the clinical time for nearly all of those pharmacists is paid through the physician group and through value-based dollars. Many of these positions started when we were in a relatively lucrative plan for a Medicare alternative payment model back several years ago. So the practice is a pretty typical advanced ambulatory care practice. Our pharmacists do collaborative therapy management, provide consults, and some of them also do transitions of care. And as I said, they're funded through value-based program dollars primarily. Some of those programs are sunsetting, so we have been motivated to look for alternatives. So how did we start? So I have a timeline here of what we've been doing and when we started this. Back in June of 2021, the state of Colorado approved pharmacists as Medicaid providers. And that started thoughts of like, wow, we should really take advantage of this. It took us until November of that year to actually start the credentialing process. Our pharmacists here are all paid, as I said, through our physician group. And so that was actually fortunate for us because the physician group obviously has done credentialing. So at least they had an idea how to do it, although they'd never done it for pharmacists before. Then really we were stagnated for quite a while. It took until really July of 2022 when one of our medical directors said, "What's going on? We need to get this, going," and convened a meeting that we really got some heads together and started making some changes. Dropped our first bill. One of our pharmacists here did that in December of 2022. $15.02, the most hard-earned $15 ever. Then in August of 2023, thereon we've added different billing opportunities since then. And you can see along the bottom, there's a graph that kind of matches up in terms of the amount of revenue we've generated, which is an approximation of the FTE that we've expended on our pharmacists. We've got throughout this time period between 8 and 10 clinical pharmacists who've been employed and working on this process. So we're starting to make a little progress, as you can see most recently, but it's been a while. So what are some of the barriers? Some of the challenges were just, especially when we started, and even still, who's in charge? There isn't a department for pharmacist billing, either at the School of Pharmacy or at CU Medicine, the physician management group. Credentialing was challenging. We did have a professional credentialers helping us, but it was very, very new for our pharmacist team. And this was also done a little during pandemic times. And so getting all that together, getting an administrative person who could figure out how to work the software continues to be a challenge. Then number 3, the who cares. Didn't actually expect that to be such a problem, but it actually was. There was maybe apathy, I could say, in many different places about this whole process, even initially from some of our pharmacists. But the people who really got this to go was really the physicians. So our physicians really cared and our pharmacists did care, but some of the people who actually have to support you through this process, who work in the business side of things, don't really understand what this is all about. And that knowledge gaps existed in those same places, really in all sides. Pharmacists, our team didn't really even know what a CPT code was to begin with. And the business side people helping us through this process really didn't understand what pharmacy practice was and how it's different.
You wanna do that? We can just go together.
Yeah.
Okay.
I reached out to Nina to meet up too.
So we have
We have
We
a
have
live
the-
mic. It looks like Lauren Wilcox.
Yeah, but, it's one of those like cars I offered to me.
Does the host have ability to mute?
Oh, yeah. So
Oh.
did I tell you I retracted my computer tomorrow?
I'm trying to mute
I
everybody.
did see that Amanda's update.
Oh, did she
Yeah.
send out? Okay, okay,
Yeah.
yeah. I don't know where she put me,
Happens.
like clinic or go.
It says.
I don't know if getting your
Okay.
live.
Wasn't Connie going sick today?
I
So part of me
saw-
wondered if she would be sick tomorrow.
That's what I was like when I was like, it's
Well-
just fine and all. I mean, it's only like 7 feet.
Yeah.
Like, I would have been
We don't have
fine,
mutability.
But,
Can you still hear me,
yeah.
folks, if I keep talking over that?
But yeah, no, I think we
Right.
need to know.
Yes.
I was gonna say, I mean.
All right.
Yeah.
I mean.
Well, okay, get knowledge gaps on all sides, and the other last part is that not all of the activities that pharmacists do are billable. Okay, so what are the methods that we are currently using to bill? There are 4 different pathways we're using. There's direct billing. We have pharmacists in Colorado are recognized as providers. That's what providers do, and that's really the easiest one, just directly bill Medicaid. We also, in our non-hospital owned clinics, are permitted to do incident to billing, which is also pretty much done the same way as direct billing, but it's the money actually goes back to the provider. In our situation, that works pretty well. Third option is there are some things you can bill, such as annual wellness visits under direct supervision of a provider. So the billing is actually done by the provider, but the services are provided by the pharmacist. And the fourth is general supervision, and there are certain codes, which is probably our newest area of work, that you can also provide under general supervision by the provider. And I'll tell a little bit more about these in a minute. So the direct Medicaid billing, that's pretty straightforward, as I said. These are the codes that we use. They are standard evaluation and management codes for either telephone or video or office visits. And most of the care I'd say that our pharmacists provide are telephone, but we do have some of our practitioners who also do more in-person care. These are limited to services that are provided through collaborative practice protocols. Incident to billing, we can do in our non-hospital based practices. In a hospital owned practice, incident to billing is not permitted because that care is presumably covered under facility fees. This also is very similar to the way we do it. It's still time-based evaluation management. It can be done on the same day or a different day from a primary care provider. If it's done on the same day, the time that, and that provider did time-based billing, the pharmacist can add their time on to the time that the medical provider spent. The stipulation with, where is this allowed is that the services that you provide need to be documented in the primary care provider's plan. Doesn't need to be anything real extensive. It can be, pharmacist to manage hypertension or to educate on diabetes care or something like that. Third is direct supervision, and this is Medicare annual wellness visits. There are a lot of places in the country that do Medicare annual wellness visits with pharmacists. There's 3 kinds. The initial preventive physical exam, or IPPE, is done once per lifetime. Sometimes they call that the Welcome to Medicare. That involves a physical exam and is not, pharmacists cannot do that particular one. They also can't do the initial annual wellness visit, which is really the first annual wellness visit that isn't an IPPE. And what they can do is the subsequent annual wellness visit, which is really everything that occurs after the first 2. And so this is really what most of them are. The focus of these visits are preventive care, filling care gaps, and reviewing medications. One question that our team asked, and others probably have, is why would a pharmacist be doing this? Because there are several things in this visit that really don't seem very pharmacist appropriate, like doing colorectal cancer screening and making sure that other cancer screenings are up to date, for example. But there's quite a few things like medication review that is. And so our pharmacists who have led this effort on our side work in our seniors clinic, and they deal with very complex patients, and they've developed a process that involves a fairly extensive comprehensive medication review in here. And their providers are delighted with the care they're providing. Their patients are delighted. So it's really worked quite well. But this wouldn't necessarily be the right thing in all settings. General supervision care is our newest pathway. These codes, our care management codes, are the ones that I'm talking about here. These are performed as clinical staff. There are similar codes that could be performed by a medical provider. They are based on billing or time that is spent over a calendar month, and they add up all that time. So if you see a patient 2 or 3 times and the time adds up to 40 minutes or whatever, you can bill for 40 minutes for that calendar month. So to be able to do that, you obviously have to have a way to track that time. In our case, what we did is we got a report built within our EHR, which is Epic, that can track time. It's not a perfect process. It took us more than a year to get it done, but it does do the job. It also, these bills or these codes require patient consent. And then the services that you provide include comprehensive drug management, collaborative care, hypertension management, diabetes management. The time spent could also include whatever time you spend in care coordination. For example, having to call the patient's pharmacy to determine refill history or some other type of a thing. There are 3 codes here: principal care management, or PCM. The patient has to have 1 chronic condition. That's probably the condition you're working with. And you have to have at least 30 minutes of time to drop the first bill. And then additional 30-minute increments could be dropped if you spend up to 60 minutes in a month. Chronic care management codes work pretty much the same way. The difference is there are 2. The patient population are patients who have at least 2 chronic conditions. And also the time only requires 20 minutes per month to be able to drop a bill for that. So you don't have to be managing at least 2 conditions, but the patient has to have at least 2. And so the reimbursement for that is a little bit higher than for principal care management. And then there's complex chronic care management, which is more complex decision-making, and those require at least 60 minutes in a calendar month. Other codes that we're exploring at this point, and we really haven't yet gotten started using, are advanced primary care management, principal illness navigation, And ASCVD risk assessment and management codes, these bottom ones here are actually new in 2025. And the assessment, for example, could be dropped during an annual wellness visit, which would be a logical time to do an ASCVD risk assessment. So we haven't, if anybody's using in those, I'd love to hear your experience. So to summarize, in our different settings, there's different pathways for being able to generate revenue and for different insurers. So that's what this table will show. In our hospital-based clinics, and community clinics, both, we can just bill Medicaid directly. That's very straightforward. For our Medicare fee-for-service population, we can bill the care management codes. We can bill those to pretty much everything. But we also have annual wellness visits as an option. And in our community practices, we have all those options, plus incident to E&M codes are an option for just about everything else you do. And then for our commercial plans, the options are a little bit less for the different types of, whichever setting you're in, but we could either do care management codes or E&M. So that's a summary of what we're doing. And so any, I guess, questions we'll do after. Is that right, Julie?
Yeah, I think so.
Turn it over to Dr. Kroon. All right, I will stop sharing.
Okay, and Julie, are you putting my slides up?
I certainly can, unless you would like to put your slides up.
Yep, I thought you were going to have them. Let me do it. Maybe Sarah, would you maybe just take a couple questions while I get that set up for myself?
Do you have any questions?
There's a few questions in the chat, Sarah. I don't know if you can see those.
Sure.
So the first one's for subsequent annual wellness visits, can pharmacists bill with director's supervision if the state doesn't have provider status?
Yes, because this is Medicare and nobody has provider status for Medicare. So it's a federal thing. So yes, they can. Then do these billing limits apply across the care team for a single member of the care team? I'm not sure what that means. Which billing limits?
So when you were showing the chronic care management
Mhm.
billing codes, you had limits of like 2 per month, things like that. So I was wondering, does that count for 2 if the pharmacist does it 2, or if a care manager does one and the pharmacist does the other? Is a limit of 2 per like patient?
Yes. So chronic care management codes, only one provider can drop, or they can only be dropped once per patient in a calendar month. Now, it can be multiple people. It could be a care manager and a pharmacist who are both participating in adding up that time together. And so, but the total time that month is still limited to, for example, for PCM, for up to 3 codes, the basic code and the 2 add-ons. And so that's 90 minutes. So all that time's added together.
Okay, so it max out at 90 minutes.
Yes.
Thank you.
Yes. Then does your hospital-based pharmacist visits not drop a charge if the patient has been, oops, it moved. Seen by the provider on the same day? Our hospital-based pharmacists, do not do any work with adding on time to, I think they're asking if you could add time to a provider visit. We don't do that, but that might actually be something that could be done if they think that's what you're asking. And why are there fewer opportunities with commercial payers? Well, Medicare annual wellness visits are under Medicare. So that's the only thing that's really very different between commercial and that. So you ready, Lisa? You look ready.
I'm all set. Terrific. All right. Good morning, good afternoon, everyone. I'm Lisa Kroon. I am a professor of clinical pharmacy at the UCSF School of Pharmacy, but my main role is as the Assistant Chief Pharmacy Officer at UCSF Health, and I oversee all of our ambulatory pharmacy practice. So I'm going to build on what Sarah has already shared, and really try to share our experience, our journey, and some pearls as you start your journey for billing. Okay. There's my arrow. Okay, so our ambulatory billing practices. So kind of, where to even start. So as Sarah has mentioned, you want to first determine your clinic mix. So our clinics in your health system, what we call on license or facility based, these are also called GAC clinics, or are they off license and physician based? As Sarah outlined, there are different billing types that you can do for an on license versus off license. Next step, I would recommend engaging with compliance. So what type of billing options, and Sarah nicely outlined many of the types. And each institution's compliance may have different interpretations. So for example, in our University of California system, we have 5 main academic medical centers. And as we share our best practices with each other, we find out that our compliance advice is not always consistent. Some may be a little bit more conservative, others might be a little less conservative. So just to know, if maybe I'm saying something here and you go back to your compliance and they say something different, that's not unheard of. At UCSF, our office is called the Revenue Cycle Compliance Program. And I've worked with different people in compliance over the many years, and sometimes they've told me different things. So basically, I want to work with them closely, follow what they recommend. And right now we have just an outstanding compliance person who really understands PharmD billing. Next up would be to check in with your revenue management people, the actual people who track the billing and the capture at your institution. So at ours, it's called revenue management. What's a charge versus what's a capture or remittance. So for example, for Medicare, for us, our charge is, I think it's about $180. Well, that's not what we get back. We might get back $90 for an in-person visit. So just kind of understanding, depending on the reports. I used to have a report that showed me all the charges, and I thought, oh, this is great. But then that's actually not what comes back to the institution. Funds flow. So where does that revenue come? How does it come back? For our ambulatory business unit, all the funds go back to the clinic. And we do facility fee billing primarily. So those funds go back to the clinic, not to the pharmacy department. So our pharmacists who are supported by the clinics charge their time to the clinic. They charge to that cost center. That's how we have that set up. Faculty who are not on the hospital report necessarily. We do, again, a charge transfer for whatever percent effort they're spending in clinic. Next step would be any EHR template builds for your pharmacist now that they're going to be charging. And I'll show a screenshot momentarily. And then, of course, pharmacist training and job aids, very, very important. And I would say this is a continual effort that we do. I just did a coffee and learn for billing for all of my ambulatory pharmacists because new ones may come on, others may kind of forget things. So just kind of an ongoing touch point with your pharmacist, I would recommend. So what has our billing journey been at UCSF Health? Our credentialing and privileging is handled centrally. We have what's called our Office of Medical Affairs and Governance. So we're really fortunate that our pharmacists undergo privileging the same process as our APPs, our NPs, PAs, et cetera. That's not the case throughout University of California, but it's just really nice that, this isn't done by our pharmacy department. It's standardized across UCSF Health. Since the mid-90s, pharmacists in the ambulatory practice setting, we've had the ability to practice under collaborative practice agreements. And then our healthcare provider status for the state went into effect in 2013. So at UCSF, the vast majority of our clinics are all on license, on the hospital license. And so we are primarily doing facility fee billing, but we're looking at some other options in the future. And we started December of 2020. I had my first pharmacist drop her charge, and I said this was the best Christmas gift I could have received. So this is just some of the technical language around Medicare. And I'll just highlight a few points here. So this are the Medicare outpatient prospective payment system. The term
Sally has done
incident,
a lot for us over the years. Yes.
the term incident to billing, as Sarah mentioned, is usually applied to your off-license clinic. But if you actually look at the language for Medicare, even for facility fee billing, it does have the term incident to. So we're a pharmacist is providing services incident to a physician or non-physician practitioner. To furnish such services like comprehensive med management, it must be under the quote order of that physician or non-physician practitioner. It needs to be face-to-face, and that could be by video, etc. General supervision is required, and generally that's considered your APP or MD is readily available or quote immediately available. And the last bullet here is that the service is integral and incidental part of that physician or MPP service, but it always must occur after an initial visit with an eligible practitioner. So while a patient may be new to you as the pharmacist, it's always an established patient in that practice. And then for the facility fee billing, the hospital would bill for that service. The other term to touch on is auxiliary personnel. So in Medicare, pharmacists are considered auxiliary personnel. And even though that makes my blood boil that we're not considered a healthcare provider, we know that we've been working on that on the federal level for many, many years. So my point here then is that we are considered auxiliary personnel, but the supervising physician or NPP, whenever I say physician, you could say APP as well, must still continue to see that patient periodically. So it's not that a primary care physician is referring a patient to your pharmacist, and then they only see that pharmacist. That the referring provider must continually meet with that patient. And I don't see that as that's just how we practice, but just to point out that it's not a full-on referral. So in terms of this order for billing purposes, I have the elements here. I think all of this, makes sense. Patient name, the date, the service that's being requested, the reason, the name, and then the signature. Now, when I first met with our compliance person in 2019, they were saying, oh, you need to have a special order by the physician. And I said, well, why would we do something different than how physicians refer to other physicians in a practice or in a health system? So I was able to convince them that a referral, your usual referral, can serve this purpose. And we worked continually to refine what this referral looks like. So it's standardized across all of our different ambulatory clinics, with our specialty clinics, with our primary care. And then the services are just built out in terms of, it might actually say, I'm requesting hypertension management. And the provider can actually enter their goal hypertension for that pharmacist to all be on the same page. That referral or order, if you're audited by Medicare, needs to be retrievable for each patient encounter. So they need to be able to find that referral in your EHR. And then with this, we really need to engage with your front desk clinic staff. So they're aware, just as you might refer a patient to an endocrinologist, they have to have a referral. So in order to see the pharmacist, that referral needs to be in place. That's how we've set it up at UCSF. And this is just a screenshot of what it actually looks like. We have Epic on the left there that would show up as your preference list. And these are the billing codes for Medicare, our Medicaid, and then also commercial for level 1. That's what we're able to do. And so that those screenshots there, you just need to, we put an IT service ticket to get those templates added to the pharmacist template in Epic. So that's just general facility fee billing. And Sarah mentioned the other way to sell your services is that the pharmacist is adding value, whether that's in a value-based care model, or it could be QIP or others. And this is just an example I'm showing of one of our pharmacists in our primary care practice. We had identified a health disparity in hypertension achieving target in our Black African American patients versus not. And what I'm showing, this is our target level here. Black is overall, the yellow or orange is our Black and African American patients, and the blue are not. And here in the purple, that's when the pharmacist started to see the patients who were not at target. And you can see a really dramatic shift in meeting the target. So this has gone a long way, and it's actually going to help me justify a couple more pharmacists for our primary care practice. A real quick mention here in terms of looking at targets, and whether it be diabetes, A1C targets, or blood pressure, is our denominator in this are always patients who are referred to us because they're not at goal, right? Whereas if you're looking at overall targets for a physician panel, for example, their denominator is their entire hypertension population. So just always be careful on trying to compare apples to apples here. Sarah did mention the care management services. I'll just highlight kind of what we're doing. So for these care management services, pharmacists meet the definition here of what's called a clinical staff. So you can be added on to the time and the care for these. A patient is enrolled, they consent to enroll in the care management service, and that's usually done by the physician or APP. For the chronic care management, we're doing this now for our in our advanced heart failure center. There is a monthly time threshold or limit in these. The new advanced primary care management, which just became effective in January, we're looking to implement these in our primary care practice. There is no monthly time threshold, so that's a unique feature with those. And then we're also looking at transitional care management codes in our primary care practices. So some newer options, and these all provide some pretty good revenue. So a couple pearls that I thought I would share. So one of the things that comes up is we open a new clinic. We actually opened a whole building last year with several floors of clinics, and I have 6 pharmacists in them. The clinic administrator is saying, oh, well, what kind of billing could a pharmacist do? And then they reach out to our revenue management people. No, if you have a pharmacist, if you have a billing process set up, have a primary contact in your pharmacy enterprise for billing questions. And so, because we just kind of go through the whole motion again where we know what we're billing. So that happened in one of our clinics, our pain clinic. The clinic administrator starts to say, oh, what could a pharmacist do? Instead of just saying, you know what, we already have this all set up, we'll implement it for our new pharmacists. Kind of mentioned already, refreshers for your pharmacists ongoing in terms of billing. People, just kind of, I don't know if any golfers out there, you always need a little refresher every now and then. One question that continually comes up for facility fee billing is, can the pharmacist bill on the same day as another provider? The answer is yes, absolutely. So the clinic, sometimes our front desk clinic staff get confused on that. Another part in terms of ordering medications, labs, and your EHR, for Epic, you have what's called an ordering provider. And then right below that is the authorizing provider. We've set that up so that the pharmacist under collaborative practice agreement is the ordering provider, and we have the pharmacist for the authorizing provider put who that referring provider was for those services. I meet with our rev cycle on a routine basis to kind of take a look at our revenue capture. So I would recommend that. And then, of course, yes, dollars are important, but we have other non-financial metrics looking at, again, the clinical outcomes. If you're in VBC, very important. And then patient and provider experience also can be a good sell. So if you can look at the provider's NPS, net promoter score, and if you show improvement in that because you've added a pharmacist to the team, that can be very compelling to your practice. And then my last point here is if you have outpatient pharmacies, there may be unique billing opportunities for a licensed pharmacy. In California, we have had a couple more recent laws for Medicaid and commercial, which is calling it a parity law, kind of like what Washington has, and where pharmacists need to be paid for the similar services that a physician or NP would provide. We have some MTM as well for Medicaid, and then some other it's called AB 1114. So some of the independent pharmacist furnishing authorities and services, we can bill for those, but again, it comes from a licensed pharmacy, not from the clinic. Currently, we're working to adjust for that. And then finally, clinician administered medications. We just started this a couple weeks ago. One of our pain points for the clinics for these clinician administered drugs is that if you have to go to an infusion center, we don't have space for that. So we just started with PrEP, with one of the PrEP medications, long-acting injectable, where the pharmacist is billing, medical billing. And that, if anyone wants to chat with me on that offline, it was a lot of technical steps to get that set up in Epic and in our outpatient pharmacy software. So that's just to point out clinics, but also there may be some opportunities for you in your outpatient pharmacies. And that's it for me.
Great. All right. Thank you very much. Okay. All right. So with that, I know there was some awesome conversation going on in the chats, and hopefully we can continue along that theme with within our breakout rooms as well. So for the purposes of time, we're going to go ahead and hop into our breakout rooms. We have 6 breakout rooms. Each breakout room has a facilitator assigned to them. So I'm going to go ahead and push everybody into their breakout rooms. You will have 20 minutes. So again, once you get into your breakout rooms, if everybody just wants to really quickly throw into the chat their name, their practice site, and their location, and whether or not you're currently billing. And then facilitators, you have your list of kind of, questions to bounce around. Again, you have 20 minutes. Go ahead, throw out ideas, take any extra time, have some good conversation. And then you'll have a 60-second warning when the rooms are about to close and bounce you back into the main room. And then I'll ask each facilitator just to go ahead and just kind of summarize main points, and we'll bring it together again to wrap it up and hopefully, have some good conversation and take some good things away from this awesome talk today. So with that, I will push everybody into the rooms. Hopefully this works. Thanks, everybody. See, did I miss you guys? Are you guys not in rooms? Gary. There we go. Keep my recording going here. Okay, fantastic. So hopefully everybody had some great conversation in their breakout rooms. What I will do now is just ask all of our facilitators to go ahead and summarize. You guys can just choose one of the categories. Am I still sharing my screen?
No.
No? Okay. I don't know if I didn't know if it went away when I went into the breakout rooms. There we go. Okay, so if everybody just wants to choose one of the categories that I have there, you can choose, a key insight that came up, a challenge, a strategy, or a tool, or a takeaway. So something just really brief, take about a minute or so. We have about 5 minutes left. So we'll start with room 1, which was Sarah's room. Just go ahead, and if you could share with the group something that you guys took away from your room.
I could say we started talking about opportunities to implement care management billing, CCM or PCM codes, and the tools you would need to get built in place to take that away. We also talked a bit about just the barriers that our billing people don't necessarily know what pharmacists do.
Yes.
Care mixes make that all the more complicated.
Yes, for sure. Great. Thank you. All right. Anna, our room.
So kind of building off of what Sarah said, I guess one of our key insights and also lumped it with a challenge was the need for credentialing. I think that was echoed by a few people on our chat. And then how it's kind of difficult to talk with non-pharmacists of how to like credential pharmacists, because a lot of health systems, have never gone like through pharmacists with medical billing, credentialing. So I feel like that may be something that we as a subcommittee or ACCP could even help, with that kind of like a how-to guide for maybe some non-pharmacist folks to understand the billing and credentialing side for that. But yeah, we had a great discussion in our room, but that was probably what everyone mentioned the most.
Yes. Fantastic. Great. And in Lisa's room?
Same comment about credentialing, that if your pharmacists aren't, haven't gone through that at your institution, can be challenging. One of my group members struggling with speaking with the people who handle the coding versus compliance, and they don't always talk and connect. So to get all the different teams that are involved in the billing process at your institution can be challenging. And then just starting it off, the pharmacists can feel a little uncomfortable and kind of dropping that first charge in the EHR.
Yeah. Yeah. Scary when you're first realizing you're billing for the first time. Yep. Great. All right. Carly.
Yeah, we had some similar discussions, I think, about some of the barriers being conversations that have to be had with billing or compliance, and then differing responses. Specifically, we kind of started off the conversation talking about different things that we've heard from our own billing departments about incident to billing on the same day as a physician or APP. And then one of the things we talked about was just how it is a little bit difficult to find all of the information about billing. And so we have to kind of, if you want to bill, you have to go kind of seek that out a little bit in our profession. So we're excited to be here. And I think our group had some good discussion about some unique codes or things that they took away from this webinar that they want to go investigate in their own institution. So
Fantastic. Great. All right, Jen.
Yeah, so very similar conversation. We talked a little bit about for some of the barriers, just the challenges sometimes with compliance. Some of them are more conservative. And so trying to work with billing where everybody can still have an open mind and kind of learn what the pharmacist is able to do. One of our participants mentioned that they have their own billing specialists assigned to their team. So that's really helped them to be able to have a little bit more focused discussion and build on their billing practices. The other things we talked about too were just methods to help be able to effectively track and report our outcomes, because we had some people in our group who are working on trying to start billing. And so we were talking about different ways. A lot of people are still using like Excel spreadsheets to document outcomes, things like that. But then one of our group members mentioned that in Epic, they're starting to use something called Compass Rose, which they feel is really helpful to start demonstrating some of their metrics and values that way, and outcomes that way as well, to potentially help support their opportunities to build services.
Yes, we actually just started that this last couple months. Very cool. All right, Jess.
All right. A positive, which nobody's mentioned numbers yet, but only one person said they weren't billing yet in our room. So I thought that was cool, because historically, when I've done some talks on this, most people say no. So that was a win, but I think a lot of people are engaged in this topic are here today. Secondly, we did have some wonderful collaboration. I'm sure you all did, but we had someone who seems to be doing some great stuff at their clinic. And so we were able to kind of pick their brain, because it seemed like they were kind of, on the forefront of some of these things, and we can work together and collaborate, share our contact information. That way we can help each other. Some of our barriers will be, solved by others before us, so we can share expertise. The biggest barrier that was shared that hopefully people can shed light on in this group and networking moving forward was inconsistencies in the billing department and also the compliance teams of like the incident to billings. Does the APP or the primary provider need to have their own note, or can they just have an addendum or, be a co-signer on the note? So it seems like some people were okay with co-signer and having a small, like, I agree, concur with the PharmD plan, blah, 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 versus other compliance teams and billing departments were saying, no, the other APP or provider needs to have their own separate note for incident to. So some inconsistencies anyways. So just, that was the main theme barrier that we had in our room as well.
Awesome. All right. Well, look at that, guys. It's 1:16, perfectly on time. So hopefully everybody enjoyed today's session and learned some new things, and got to share some new things. Again, I want to thank everybody from joining. I want to especially thank Sarah and Lisa for sharing their stories and their expertise with everybody. Thank you to our facilitators for leading their sessions today, and for all of the work that the Clinical Advancement Subcommittee put to help bring this webinar together. Hopefully everybody can join us on August 13th. We have our second webinar, which will be on innovative practices. So watch for our sign up and registration, which will come out in a couple weeks for that. So again, we have some exciting speakers, which will be sharing their innovative practice models coming up for that one. So hopefully we'll see you guys all then. Again, thanks, and have a wonderful rest of your afternoon. Bye.